Okay, so thank you, Rebecca, for joining us. Rebecca is a mathematical statistician leading influenza modeling and forecasting efforts at the CDC. She is in the influenza division. She was a founding member of the COVID-19 Scenario Modeling Hub and has loads of wonderful experience in modeling infectious disease dynamics. And there was a recent technical blog post, if you haven't read it, on assessing epidemic growth, which is on my reading list. Haven't read it yet, but I would recommend taking a look at that if you're interested in learning a bit more about the work that she's done before. So with that, Rebecca, would you like to go ahead?
Thanks, Kelly. And before I start, I'll mention Sam and others played a large role in that technical blog post. So I definitely don't want to take all of the credit there. But I'm happy to be here and looking forward to getting feedback and hopefully some good discussion on a project idea. So it's based on a few different projects that we have going on already. But the general idea is that we have these real-time effective reproduction number estimates that we're starting to generate for influenza and for COVID-19. And we also have forecasting efforts, in particular of categorical trends, which are relevant to the work that I'll talk about today and the proposed idea. And so that's for predicting increases, decreases, large increases, large decreases. And it seems like it should be possible in theory to connect these ideas and possibly create some kind of submission for the probability of increase or decrease in influenza confirmed hospital admissions. But I don't know exactly how to do that given sort of the definition that we're working with right now for those categorical trends. So with that context in mind, I will go into a bit more detail about how we've defined the categorical rate trend forecast for the flu site influenza hospital admission forecasting collaboration that we've got going on in the US CDC, and then also a little bit about the real-time effective reproduction number estimates that we've started doing in collaboration with folks at CFA, and then with the ultimate goal of discussing whether it's possible to translate the RT estimates that we're generating into rate trend forecast that makes sense. And I've included GitHub links here to the first link is to our hospital admission repository for the previous two influenza season, and then we shifted to using the tidyverse format and started a new repository. And so that's the second link that just has forecast starting this season. So the idea of having a categorical forecast came about, I guess it's not entirely a new idea, but right now we present ensemble forecasts. So here on the left, this is an example of a flu site forecast from the ensemble in last November. We've got the median, in the solid line, the 50 and 95% prediction intervals for 1, 2, and 3 weeks ahead, and 4 weeks ahead. But we thought that it could be helpful to have some kind of visualization eventually if we could provide useful definitions of categorical changes. So you could just look and see, is your state forecasted to have an increase? So on the right here, there's a map that has probabilities for each of the state. And here we've combined increase and large increase, which I will talk a bit more. But it's an example of an ensemble categorical forecast from that same date last season. So taking a step back, the broader collaboration for generating these ensemble forecasts. It's called FluSite. I'll be talking mostly about last season since we have some results for the categorical forecasts that I can share. The target for forecasting is the weekly number of laboratory confirmed influenza hospital admissions. This confirmed hospital admission data became available during the COVID-19 pandemic in February 2021 for flu. So there's not a whole lot of historical training data, but the confirmed admission target is really nice. And it's also at the state level, which is really helpful. So the horizon that we're predicting is up to 4 weeks. Well, that was last season. It's slightly different this season, but we have forecasts at the national and state levels, also DC and Puerto Rico. Submissions from teams happen weekly, and we start in mid-October and end in May. So last season was a really difficult season for forecasting. It was atypically early in the US. So on the right here is a plot of so hospital admissions, weekly observed data in the black curve, and then our ensemble predictions in shaded blue and gray. And you can see the forecast really struggled with this early uptick in hospitalizations. They also overshot the peak. Normally, an ensemble is pretty robust, but it even struggled in this past season. And so also it, didn't decline as fastly as we would have liked. It did well when things were stable, but sort of the period of epidemic growth and decline is the time that we're really interested in. So we were looking for a way to expand forecasts to hopefully provide more robust, useful information, even when it's hard to predict the exact magnitudes of counts in these times of change and uncertainty. So we developed this categorical rate change target. There are 5 categories, and teams submit probabilities for each of the categories. So it's stable, increase, decrease, large increase, large decrease. They add up to 1. This first pilot year, we just did at a 2-week ahead horizon, and we did rate differences and count differences. So we required 20 increases in 20 counts for an increase of 40 hospital admissions at the 2-week horizon for a large increase, in the analogous version for decrease and large decrease. And then the rate changes are based on the population, so it sort of normalizes across the states. But the exact thresholds, I won't get into specifically what those are for the different categories, but we chose them based on some the limited data that we had at the time from HHS Protect and HSN, which is the confirmed laboratory hospital admission data that we're using for the regular forecast, and then FluServeNet data, which is only available for a subset of states, but has a longer history of hospital admission data. And fortunately, those rate distributions were pretty similar. So we were able to base the thresholds off of those. So there's a little bit more detail at that first GitHub repository that I mentioned, and the first submissions took us a while to pick our definition. It was a hard season, but the first categorical submissions were in mid-December of last year, and 7 teams ended up contributing. So this plot on the right, which I probably should have started with, is the observed trends in influenza hospitalizations based on our definitions for. You can see the 21-22 season was a bit more flat versus to the right here, we're seeing a lot more increases, large increases, and then decreases and large decreases in the orange and blue. Here's an example if you look at a particular line in that graph, so different states, Mississippi, Florida, you can see increases happening, large increases, and then decreases. Some states like Georgia didn't flag, but had generally flatter trends. So it's a little hard to see the axes, but there's 200 here, 1,000 here. Georgia didn't really have as large changes as we observed in the other states. So those are just examples of what the categories look like when you look at the observed data from last season. So here I'm showing how we could communicate the categorical trends and like what the submissions look like. So we generated from the baseline model and from the ensemble what the probabilities for each of these categories would have been from the quantile forecasts that we already generate. And so you can see there's a lot of stable from the baseline, which makes sense because the baseline model is just predict flat with some noise. And then the ensemble did a bit better in terms of matching the observed trends. Well, it did a lot better than the baseline, so that's good. But there's still a lot of work to be done here in combining the forecasts, and we're using a slightly different ensembling method this season for the categorical forecasts. But again, here's the visualization of what a map might look like in the future, that once we have some time to evaluate this alternate forecast that we could potentially share. Okay, so shifting gears a bit to talk about the RT, real-time transmission estimates. It's been a collaboration between my center at CDC and the Center for Forecasting and Outbreak Analytics. I have some acknowledgements here. Definitely want to acknowledge everyone that's been involved in this work. I think probably people are familiar with the definition of RT, but it's a time-varying reproduction number. So it takes into account population susceptibility and behavior. It's estimated from data and can sort of capture these unseen trends or mechanisms that we don't have data on. So I'd rather spend more time on discussion, but basically we're doing these estimates using the same set of hospital admission data, and they can kind of tell us whether transmission has been increasing or decreasing, rather than just looking at the trend of the data. So it's an additional source of information, and we would like to leverage it in as many ways as we can. So here, just showing again, it's the same hospital admission data set that we use for the forecast. We're using EpiNow2 to generate the RT estimates. This is an example of observed data. These estimates are being generated both for COVID and influenza. But generally, since we're producing these estimates of whether transmission is increasing or decreasing, it seems like that could possibly be translated into a forecast of or a probability of whether we'll see increases or decreases in upcoming weeks. So that's where the ideas are connected. This is an example visualization for influenza. We are providing RT estimates for jurisdictions with fewer than 10 counts, 10 hospital admissions observed over the past 2 weeks. And you can see this is not the most recent run, but we have lots of states increasing or likely increasing for influenza, which makes sense because we're getting into, so this was November 4th, and we're definitely getting into the start of the influenza season, and there's definitely transmission. The map now is a bit more purple than this one. And hopefully these will be available soon, and I'm sure we can pass along that information when these estimates are publicly available. But this is a more technical definition of how the probabilities of increasing or decreasing are established for that map. So it depends on where the credible interval falls for that RT estimate relative to 1. So if the full interval is below 1, we're pretty sure it's decreasing. If the full interval is above 1, pretty sure it's increasing. There will also be information about caveats and limitations. Again, this is the map, so it's a bit more recent, from November 25th. Lots of dark purple states that are increasing. Alaska and Puerto Rico kind of stand out as the 2 states that are decreasing or likely decreasing, but we have seen, certainly for Alaska, it seems like their season has already peaked, and similarly for Puerto Rico, they've had a pretty big season already. So there are state-specific estimates, and these are probably what we would use to try to convert to some kind of forecast. But it's that translations piece that I'm hoping we can discuss. So that's the end of what I have prepared, but I'd love to discuss a few things. So do these trend forecasts seem to have additional utility beyond our typical count forecasts? Do we think it might be possible to use these RT estimates that we're generating more regularly now to sort of create a submission for a rate trend forecast, or probability of each of those categories that I mentioned? What translation steps would be needed? This probably would take a lot of thought, as they're defined on what their thresholds are, and it's the state population is taken into account because they're rate based. How would we think about incorporating time delays? They're not exactly on the same time scale in terms of RT, being an estimate of transmission or infections, and we're trying to forecast hospital admissions. So with those ideas in mind, does it make sense, and is this worth pursuing? I'll just quickly acknowledge collaborators before we get into the discussion, along with all of the flu site forecasting teams, public health officials, reporting hospitals. I know it takes a lot of work to collect this data, but it has been really exceptional to have state level confirmed influenza hospital admissions. These are the teams that contributed categorical trend forecasts last season. These are the teams that submitted forecasts in general. And this is my caveat slide that the findings are not necessarily the views of CDC. And also my email is provided along with the flu site email if you have questions or thoughts after our discussion. So I'll go back to the discussion questions and would be happy to chat.
Thank you, Rebecca. That was a really nice presentation. And it's nice to see some work where we do have quite a bit to discuss, I think. Like, it's not like done, dusted. I think, we could talk about some of these questions. And so if anyone on the call has a question, feel free to raise your hand or put something in the chat, and then we can start going through. Sam, would you like to start?
I would. Really interesting. I like this a lot. I just had a question about the categorical forecasts. And I think you said that 7 teams were submitting them last year. From looking at them, it looked like they were something you could have got if you wanted to from just transforming count forecasts. Were you not able to just transform their submission or kind of like provide them with a code submission? And if you could do that, did you look at the difference between the categorical forecast you would have got if you'd done that versus what they ended up submitting, i.e., were they different things?
Great question. Yes, you definitely can convert back from the quantile, like the cumulative distribution function of the quantile probabilistic forecasts. Interestingly, the teams that submitted last season had different methods for doing that, so we let them use their different methods. But this year, I think we have something like 20 teams submitting categorical forecasts now. So I think that they've realized that it's possible, it's not that hard to do that, to do some kind of translation to get the categorical forecasts from forecasts that they're already generating. I hope that we'll have models. There's at least one model that's not just the translation from the normal forecast, that's more of a model specifically well, it's based on their simulations before doing the cumulative distribution function. But I think it would be great to have models that are sort of more directly aimed at this target than just that translation alone. So we are not transforming the normal forecasts for teams, but a lot of teams are basically doing that, at least in the results that I've showed. And we did compare the, so we did the conversion for the flu site ensemble and the baseline from those forecasts. And the categorical trend probabilities that you get from the ensemble of all of the forecasted, or all of the forecasts that were submitted and ensembled, did not perform as well as an ensemble of the categorical trend probabilities directly, which I think makes sense for a few reasons.
Was that for the 7 or the 20?
That was for the 7. So it was definitely a subset, and they're, maybe they're more, those teams might have a lot of experience. So that is one reason, but I do think that it's possible, but probably needs more investigation, that ensembling the trends directly, you might preserve more of the signal than you get if you ensemble the probabilistic forecasts and then try to take out the categories.
Okay, I'm going to ask the next question while other people think of things. So for those who are not at CDC, I think it might be worth discussing the concept of the map, because we were doing some similar things for MPOX, which, I mean, there was like endless discussions. I think there's a lot of interest in showing trends in that way, like with a color for each state. And we kind of like to rank the states in that way, which the states sometimes don't like. But I think what we kind of got tripped up on and why our map didn't ever really make it to prime time was because, I mean, the audience wasn't clear. So anytime you have some kind of graphic, you have to think about what's going to come from that. What is the public health utility? And is it the public, like the general public? Are they going to look at this map and say, oh, maybe I should wear a mask or stay home or something? Is it hospitals? Is it like local public health when they're like thinking about planning? And I know you're working with Inform, which is great because that's sort of what they do. But I think really thinking critically about who the audience is and also how frequently you're going to update it. Is it going to be once a week? Is it going to be every 2 weeks? Like, what is that going to look like? So I think we always like to do these maps, but I think whether or not this comes to fruition, whether it like makes it to prime time, will come down to a lot of careful thinking about maybe how you sell it and what's the ultimate goal.
Yeah, I'll just mention, so we've done a lot of work with the RT estimates for how to communicate those, and it's really challenging. As you mentioned, the states do not typically like being ranked, and I'm not sure that it's as helpful. But if we can communicate what the estimates are and they can kind of translate that in their own context, I think that that will be more helpful. We did do some user testing for that effort. The categorical forecast is definitely way farther away from potentially being shared. There's a lot of evaluation work to do to make sure that the estimates are robust and useful. So I agree that thinking through like what the messages are, and there's like some work, in communicating what the thresholds are. We tried to make it state specific in that so they're rate based. So like per your population size, or at least taking that into account, so that hopefully adjusts for some of the differences across states. How we message it would definitely, different audiences would require different considerations. So yeah, that would definitely be like a whole other piece of work that we would need to do before going to.
Yeah, and the issue too about state level versus local, like if you live in a super rural area, and all of the transmission is being driven by like cities or urban areas, how relevant is it for, you basically? So yeah.
Agree.
How about Seb? Because Sam already asked a question.
Thanks very much, Kelly, and thanks, Rebecca. That's super cool and touches on stuff we've been thinking about and discussing a lot. So from my perspective, there's two different kind of directions of research, as it were. And that one is, or two kind of fundamental questions. One is, how do we best communicate forecasts? Where I think presenting a mean with some uncertainty is certainly not the best way to communicate forecasts. And I side with, I've once been told that people understand probabilities, but they don't understand confidence intervals. And I think we should maybe communicate our forecast more in terms of probabilities, or what's the probability of exceeding something, what's the probability of going up versus down and everything. And I think your work touches upon that really nicely. That would be one question, like how do we best communicate forecasts? And the other question would be, like, how do we find the best models, or how do we generate the best forecasts for what we care about? So it's more about kind of model selection, and do we generate these forecasts kind of from the other forecasts, as Sam suggested, or does it need separate models and all of this kind of stuff? Which of these do you think is like the key one? Which of these are you mostly interested in from those two? Where would you focus your kind of efforts?
Between communication versus doing.
Yeah, between like finding the best model to make this forecast versus the communication.
Yeah, I think I would be really excited to see more modeling directly at just increase, large decrease, or the categories themselves, and less as translating from the forecast that we already have. There may be epidemiologic, so Sam asked why in the chat. There may be like epidemiological dynamics that we can't get the magnitude, but if we have some measure of susceptibility, or like that, how much of the population is left, or that could be infected or hospitalized. I just think that there's a lot of valuable space there that hasn't been tapped yet. And I don't think that you need, or I think not that you don't need a number of how many hospital admissions, but depending on how confident you are in that number, like, is it really helpful, as opposed to just, we think it's going to increase by at least as much as you said. And I do think, I agree, like it's probabilities are I think a good way to communicate, and that's where we've been going with the real-time reproduction number, as well as to communicate probabilities of increase, decrease, rather than the credible interval of the actual estimate, which I think is a positive direction. So yeah, I would love to see more modeling like directly of the dynamics. In addition to already coming from the forecasts that are happening, like I don't think we should, throw those away. Obviously. But I do think that there's additional value that we could bring into forecasting overall without, trying to get those exact counts necessarily. And yeah, I agree with communicating probabilities. So yeah, the categorical, is it going to increase or decrease in your state? But agree with Kelly that, if you're California, you're a big state. And so you could have trends driving one area that then are not representative of the entire state. So we'd have to think about that and communicating. But we have great colleagues in California that could perhaps help us.
Okay, how about we go to Caitlin next?
Sorry, Sam, I cut you. Okay, I have two questions. The first is, how do we evaluate the categorical trends? Do you guys use Breyer scores, or I guess I'm not sure if it's probability of each category? Is that how the team submit?
Great question. I do have a preliminary work slide, and I need to add, it's not on the slide itself, but need to thank Jessica Davis at Northeastern University for spearheading a lot of this work, and along with other teams that are also using the Breyer scale or Breyer score to evaluate their forecasts. But it is definitely not the traditional weighted interval score that you would use for the other forecast models. So there's a reference model, at least for the Breyer scale score, and some of the baselines we've considered are equal probabilities across the models, or across the categories rather, which is not a great baseline, but it is a baseline. Another model that's maybe more of a model, getting at sort of another option to create a forecast for these targets that's not directly translated from a probabilistic quantile forecast, is what's the percentage of states that are in each category in the previous week. So, as that increases, you might expect the probability for any given state to increase as, sort of an indicator of the season is starting. So that's sort of another model that we can consider. This is an example. So yeah, preliminary work, but comparing the different models to the different baselines, and you can see when you consider the percentage of states, that model does better than the flat baseline. So, but yeah, these are very preliminary results, and maybe that starts to answer your question of how you would evaluate it.
Yeah, no, as soon as you said that, I was like, wait, I remember this from my desk. You presented that slide, so sorry.
No, no worries.
And then the other one is more of a discussion question, regarding communication. How do you guys think that we as a modeling community should be communicating the value of RT versus a visual inspection of trends? And what are the key distinctions that we need to highlight to point out where it matters, right truncation or date variability / noise in data that can misconstrue the recent trend?
Great question. It's something we've been thinking about a lot. I think one of the biggest things with RT is just acknowledging that it is a trend indicator, and it's a trend indicator for transmission, not it's not just the trend in hospitalizations. So, right, that's the first thing we want to communicate, because you say is a trend based off this data, but it's not a trend in that data. So that's one way in which RT is, really different. Also, it's an indicator of increase, decrease, but not actual burden. So we really have to consider it alongside of other data sources like the hospital admissions. or emergency department visits, or whatever your data source you want to use for actual levels of burden, because you could be still having like a high level of burden and decreasing, and want to not miscommunicate that into low risk from decreasing while it's still actually kind of a high risk situation if you're, say, near the peak.
I'm going to add something as moderator using that privilege. And it's about visual inspection of trends. In the Mpox outbreak, I was sad to see that some people were still looking at an epi curve and kind of squinting and being like, yeah, I think it's going down still, and using that as like an assessment of situational awareness. And I think we need to do better about communicating delays in reporting, and that kind of feeds into RT and some of the methods that are, like EpiNow2 that adjust for those delays. And yeah, like those biases I've been thinking a lot about lately, and I think a lot of people are confused about them. So I think we need to do better in communicating like the delays and the biases, and that's the added value of modeling, I see. So we just need to maybe communicate that better, either have better not papers, but like better explanations supported by, better methods, I think, for addressing those. So
I'll put another plug-in for the technical blog post, yeah, that Sam also put a plug-in for in the chat.
I know the blog post is on my desktop. I need to read it. Maybe on my 11-hour flight back. Sam, do you want to go ahead?
Yes, I have two questions. So I'll ask one and then significantly pause and let someone else jump in, and then maybe ask the other one. So the first one is, there's this like a lot of kind of trend around categorical forecasts and things, and this kind of transforming forecast into probability of increase, decrease, etc. Have you had a lot of requests from people to provide forecasts in that format? So we provided, that kind of feature in EpiNow2, so we could make a map, essentially. But I don't think, and then people seem to like it, but we never really had any, we were never really close enough to decision makers, I guess, to know how much they liked it, or if they actually wanted it, or if they were just consuming it because we were giving it to them.
Good question. I don't think anyone came to us before this and asked for it. But I do think that there's interest in, as Seb mentioned, the probabilities more directly than trying to interpret the prediction intervals. I think it's, and I like the maps and think that they're, a bit more intuitive. We have had discussions in so like a forecasting meeting with the Council for State and Territorial Epidemiologists, and there seemed like generally positive feedback. Definitely that, we want them involved in the conversation